That's a good question. I mean, the SCD-PROTECT, I mean, to set maybe the landscape here, was probably it is the largest experience of wearable cardiac defibrillators post-discharge with a new onset lower ejection fraction or HFrEF in the setting of MI or non-ischemic, as you indicated. And I think the key part here is that, first of all, it's very, very large, and it's actually countrywide experience, over 19,000 patients in Germany. So it actually reflects systematic use in a multi-center national level. It is done on top of very good GDMT, and there are several learnings from that are also rattled down here. One, the patients leaving the hospital were quite balanced. You had patients with ischemic, non-ischemic cardiomyopathy, really indicating that we don't prescribe these things only in ischemic cardiomyopathy. Both patients are at risk. B, the incidence of shocks, appropriate shocks, was really proximate to the discharge, as we would suspect. The acute event of new onset reduced ejection fraction really then resulted in the event clustering very, very early on in the first 1 to 2 months post-discharge, meaning that if you want to wear a variable cardiac defibrillator or you want to protect yourself from sudden cardiac death risk, ventricular arrhythmias, you want to do that really, really early once you leave the telemetry bed of a hospital where you were admitted for new onset heart failure, for example, or post-MI. And so that was the second learning. And then the numbers themselves were quite staggering. I think that's where the biggest learning comes in. The numbers, we report them in 100 patient years, so sort of a standardized way to report the incidence rate for events such as appropriate shocks. And here the findings were that the incidence rates for non-ischemic patients were around 8 events. If you look at ischemic, and 6 events for non-ischemics, around 6 to 8 per 100 patient years. And it was sorry, let me clarify, 6 for non-ischemics and 8 for ischemic. So it was higher for the ischemic patients, but see how the difference wasn't really that large, indicating that even non-ischemics remain at risk for sudden cardiac death events. And the key thing here is that actually that these numbers are at least twice, if not 3 times higher than what was reported from clinical trials using a more select patient population, in centers that enroll patients in clinical practice. This is not a trial population. This is a real world population where the event rates are higher than we would have expected from clinical trials with ICDs and CRTDs. So that's one thing. But the numbers are actually a lot worse if you look at the overall incidence of appropriate treatment, because I just gave you time to first, 6 for non-ischemic, 8 for ischemic. But if you go now into the totality of events, it actually goes to 8.5 with non-ischemics and 14.9 with ischemics. That's now repeat events over the 100 patient year. So the risk is real, it is early, and it is present even though these patients in this German population are very, very well treated on guideline-directed medical therapy. I think the fact that despite good medical therapy, patients have very early events and have a lot of them, it just really means that in the appropriate patients, we have an unprotected period that lasts for the first few months, where patients are going home, have a high risk, and it's early on. So if you to consider protecting them, you can't implant ICDs or CRTDs early on. This is against the guidelines. You have to wait 3 to 6 months before you reevaluate for the ejection fraction. But the problem is that the first 3-6 months then remain unprotected. And that's exactly the period that wearable cardiac defibrillators could and should be considered, and the guidelines give it a class 2 indication to protect that high-risk period. Now, one interesting finding, and it's not new to this specific study, is that with GDMT, the 4-pillar GDMT, you actually have a higher rate of recovery. Over 50% of patients recovered above an ejection fraction of 35 at the 2 to 3 month mark. What does it tell you? It tells you that, if you to protect them short term, there's a very, very good chance more than half of them will not need a defibrillator in the first place. And I think that is a learning we had again and again. As our GDMT gets better, we will need less and less durable implantable defibrillators. But unfortunately, while the totality of the sudden cardiac death risk certainly is falling over time, over the decades, but acutely it remains out of proportion high. I think to the question, maybe, who's the ideal candidate? What do we do in clinical practice? The problem with this population is that ischemics and non-ischemics are at risk. Ischemics are at a greater risk, but not a tremendously high risk. Both are quite comparable in their incident events. And there is no good predictor that I'm aware of who is at a particularly high risk when you look at population-wide assessment. So the reality is that you probably have to span a pretty broad net and protect relatively broadly when patients leave and not try to cherry pick. I think in clinical practice, my own clinical practice, my partner's clinical practice, we do see that we sometimes try to identify that patient that is a particularly high risk. But that's not what the guidelines tell us to do. There's certainly some high-risk markers. If somebody has VT all day, every day on the telemetry screen before you send them home, well, that patient's probably going to be slightly higher risk. Somebody who has a particularly rough course and maybe spent some time in the ICU, that will be maybe somebody who's slightly higher risk. But in general, there's no easy way to predict who's going to have that early event, when exactly that event will occur. Thus, a more standardized, like a checkbox approach. New-onset LVF reduction, ischemic and non-ischemic, have you considered to protect them for the short term, since it's a new onset, prior to reconsideration at 3 to 6 months for durable ICD? I think, what works for us is that if you establish workflows around it. And, I think physicians, APPs have become checkbox docs. We follow checkboxes. If there's no checkbox, we often don't follow them. So your question is interesting because the German registry demonstrated very high adherence to therapy. Once prescribed, people actually wore it at a very high rate, greater than 90% wear time, which is amazing. I certainly don't see that to the same degree in my clinical practice. Now, is this a cultural thing? Because we have not seen that in a VEST trial, which is now many years back with a large, a US trial where we saw wear times that were significantly lower. And if you don't wear something that's going to protect you from a sudden cardiac death event, it's not going to protect you from sudden cardiac death event. So that was a direct correlation between wearing and wear time with the benefit on efficacy of the VEST therapy in the VEST trial, in the per protocol analysis. So now, I do think that what we're observing right now in the German population might be a little bit also a cultural phenomenon. I'm German. I grew up in Germany, and I think that maybe, without being stereotypical, maybe if Germans being told you have to wear this, they wear this. Maybe that's sort of my take on this. But it also then behooves us in the United States that when we prescribe that therapy, to make a much stronger case to the patient why we're doing this. And I think that's really my takeaway for this, for my staff, for myself, is that we just need to spend enough time to reflect on why we're doing this. And it's not just a 1 hour a day thing. It's a 23 to 24 hour a day thing. The SCD-PROTECT study from Germany certainly presents the best new evidence over the last 5 to 10 years. So that's the good news. It is a single arm, open label registry, meaning this is not a randomized controlled trial. Whether the guidelines will now upgrade the recommendations for ischemic and non-ischemics to a higher level, I don't know. It might happen, but it might also not happen because it did not reach the the strength of evidence of a randomized controlled trial. I would argue, though, we might not have another randomized controlled trial in this population with this technology that has been on the market for, decades. So I would, my hope is less that the guidelines will be changing, but more that we have now large scale in a 19,000 patients worth of data to push us in the right direction and give us data that we haven't had for a while in a systematic fashion outside of the clinical trial experience. Now we had registry data, don't get me wrong, from Europe and from the United States before, but they were never at this size and also not as contemporary, of course. And the reason contemporary matters because our GDMT pillars are changing at a rapid pace, and this was done with the most comprehensive GDMT cadre, and so I think that this just represents the best evidence to date, and I think it will change the landscape in clinical practice, whether it changes the guidelines or not.